main pack, and then when we get to the supplementary, I think Emma might want to contribute as well. So over to you two.
Chair, if you're happy, I am going to defer to the Director of Integrated Commissioning, who will take us through it.
It's a good idea, Carol. Over to you, Craig.
Thank you, Chair, and thank you as ever, Carol, for the development opportunity. Very, very much appreciated. So within your pack, you will find the terms of reference for the Western Locality System Improvement Board. And what we thought we would do on today was table a brief highlight report, which surmises the terms of reference, the membership, and then some of the key priorities that the board's focusing on. So the System Improvement Board has been established really to drive through improvement across the Western locality, and the board's quite unique in as much as it has both commissioners, providers, and the regulators as part of that board as well, which is quite unique. And it is very much an action-oriented board with tasks which we drive through and then report on 2 weeks later. The board meets every 2 weeks. Because of the intensity needed around the system improvement, then that frequency is really important, really. And you see within the terms of reference and on that slide that there is 3 main aims, which is to reduce patient safety and quality risks across the system, to improve performance around key constitutional targets, and then also to deliver that financial improvement that the system needs. So it is very much generated around quality improvement, performance improvement, and financial improvement. And there you will see some transformation programs which we think are absolutely the key enablers, which will start on addressing some of those system issues. And we'll touch on those a little bit more when we get to the final slide. So, as I said, it's made up of commissioners, regulators and providers and stakeholders as well. And we have the regulators from both NHS England and NHS Improvement sitting around the table. At the moment, we don't have CQC, but that's something that we, as a board, we may well consider. And we have the commissioners represented through New Devon CCG. Rob Sainsbury, who is my line manager, chairs the board. And Carol represents Plymouth City Council. And then we have the providers, which is Live Well South West, and we've got Steve here to support me, and Plymouth Hospitals Trust through Joe, and we've also had SWAST attend as well. And then we have stakeholders come in as well, and their frequency depends on the topics being covered as well. So that, certainly the latter stakeholders one's quite fluid in terms of who's represented, but those first 3 columns represent the core membership really. And so why have we established the board really? And I think this slide really goes into that at a headline level. So the Western system, as this board well knows, is challenged in a number of areas, and we are seeing increased admissions and attendances at the A&E department. And that's bucking the trend elsewhere in the STP, which are showing a slowing up of that, but we are seeing a noticeable increase as well. And certainly during the course of this year, we've seen in the region of a 5% increase, which is quite significant. And certainly Derriford will now have most days where attendance is over 300, which is unheard of previously as well. So real significant challenge for them. As this board also well knows, we've had issues in the past around primary care as well, and that's been a focus of overview and scrutiny. That fragility of primary care is a real issue, and that's been demonstrated by a number of vacancies across primary care, but also clearly, as this board will know, that we've had some practices hand back contracts as well, and that has an impact across the system. As a board will also know, and it's a focus of the discussion later around CQC, we have issues around system flow, as we would term it, and that's manifests itself in delayed transfers of care, which CQC will absolutely be focusing on when they arrive in December. But also discharge to assess pathways aren't seamless at the moment, and we've had a number of peer reviews which have highlighted that we need to get better as a system, as working as one system, regardless of organisational boundaries as well. And we're very fortunate to have Joe here today, because Joe's been appointed across the 2 organisations to really drive up those bring together those disparate teams, separate teams, and join up those pathways as well. And we're already seeing the benefits of that approach across the system. As people will know, we've got some absolutely challenging cost improvement programs, and certainly Derriford in particular had a significant cost improvement program this year in the region of 8%, which is absolutely one of the largest, and certainly the largest across the STP footprint as well. And we need to work together as a system to absolutely help Derriford through that position as well. Derriford can certainly meet that cost improvement program through their own actions, and they're driving those through, but it also needs the whole system to support that cost improvement program as well. And then clearly, if people are in the wrong place at the wrong time, then it does have an impact on quality, and those risks that the system collectively needs to manage. So that's the challenges, and the initial priorities as of November really are firstly to reduce the number of people in the discharge to assess pathway 2, which is where we discharge people to short-term residential care or nursing care. And we really want as a system to embed the philosophy of home first and foremost as well. So we want to reduce the numbers in that pathway and get people home first time. And as I said, Joe's been doing some work around that as well to really drive those through. And at the same time, to facilitate that, we need to reduce the length of stay in community hospitals. And in both of those two, the initial actions are starting to really sort of have an impact, and we're seeing the numbers in both of those come down as well, which is a significant improvement. We've got a primary care action plan, which we're overseeing, and initial focus is winter planning and how we're ensuring that there's sufficient supply over winter, and all those communication messages are out there as well. So that's an ongoing process. We're in the process of developing the acute assessment hub, and that brings together primary care streaming, ambulatory care and frailty, and that entails moving the Robin unit, which people know is at Mount Gould, up to Derriford as well, to create that seamless service at the front end, to really think about how we work with frailty in a different way and stop people being omitted. That's making good progress. There's been a lot of good meetings recently, and the Trust and Live Well really working closely together, and have developed a MOU which should be confirmed next week, sign off for those two organisations to work as one on that site as well. We're in the process to develop a system-wide quality and risk framework that we can all share, we'll all have visibility, and then we can all take collective ownership of. And then, as I hinted before, we are developing a system-wide financial recovery plan. So how, as a system, do we support that big cost improvement programme across Derriford as well, those bits that they can't influence, which are dependent on others as well. So the directors of finance have been working together, and they've made some significant progress on that. The board is very intense. As I said, it's very action-focused, but we are starting to see some real improvements come to the fore now. I'll just ask Joe or Steve if they want to add anything else.
Thank you, Craig. I think that's a really good summary of where we are. I think just to reinforce, as Joe is here, Joe is a shared appointment between Livewell and Plymouth Hospitals Trust as Joint Director of Integrated Urgent Care. That has been a real clear focus for both organisations to look at where some of the gaps are and where some of the good work is, and we make best of all of that, really. Craig's right, there have been significant improvements, more to do, but there's absolute clear sign-up, certainly from Livewell, to support Plymouth Hospitals Trust and the wider system to ensure we have a successful approach to this. And I think the learning from Robin, acute care at home, acute GP service that we bring to the table, there's a lot there, and as Craig said, there will be one service at Derriford to deliver that joint integrated approach. There are challenges there, and I think also how we support primary care in particular to deliver urgent and planned care, and then also how we look at the prevention agenda in the same discussions, but recognise we've got a series of priorities here, so it is quite a challenging approach, but one I think there is absolute unity across the patch to make sure we are successful at.
Joe, did you want to say anything? Okay. Anybody got any questions or comments you'd like to make? Ruth? Thanks for that. I wondered if I could just make a comment around frailty, because that's an issue that people generally associate with extreme old age. I just wanted to make the point that in our Plymouth population, we know that in more deprived populations, the onset of frailty occurs at a much younger age, so some 10 to 15 years earlier than you would expect in a less deprived population, meaning that at a particular age, we tend to have twice as many people in our population that have frailty or severe frailty. I just wanted to make that point because occasionally it gets missed when you look at the demographics of the Plymouth population. Do you want to take all the questions?
Just to pick up Ruth's, I absolutely agree with that. And I think one of the advantages of Plymouth, because frailty also involves quite often mental ill health as a major factor, and I think how we integrate and support that approach. I suppose for frailty you could read complexity or whatever, but I think it is that importance of looking at how complex individuals are and how we bring all of our resources around to support those individuals regardless of their age, but it is something that's been recognised. Thank you.
Yes, I was just looking at that and looking at your first two priorities, and indeed the last one, and thinking of the priorities of the STP as well. And a lot of this, when you're saying we all need to work together, Steve, a lot of this is going to depend on what provision there actually is in communities. So I was just going to make a plea on that stakeholder thing, however fluid and intermittent, can we include the work that's going on in communities to support the prevention agenda.
I think that's a valid point, Jackie, really. I think, and the voluntary and community sector and the communities are having a, real impact in helping us manage these issues as well. And certainly both in terms of prevention, but also discharges as well. The contribution that Red Cross makes to the service is really important as well. So it's a good point, well made.
Okay.
Thank you. I think it's good to see this set up and some clear priorities. I guess what I'd be interested as a board member here is just where we get to understand those priorities and the improvement that's made and how it comes back to us and who specifically is looking at and bring it together in a way that we can understand and have a useful input to support what the group is doing.
So I think the intention, John, is to bring, for Rob Sainsbury, who is a member of this board, to bring a regular update to this board as well, and also to set out, attached to this, the performance scorecard, which we've developed as well, so the board will have a visibility, but also to be able to support and challenge that as well.
All right, so we need, although you're off in it, I think we need that to actually be recorded, that we do have regular updates and the scorecard as early as possible, so as we can really sort of get to understand some of the issues. Carol.
Thank you, Chair. It's building really on John's question. I think he's absolutely right about what is the role of the Health and Wellbeing Board in relation to this. So this is the first time you will have seen what the priorities are. And I just wanted to make a link to the fact that one of the things that the Health and Wellbeing Board has to do is set the priorities around commissioning and making sure that we were set the challenge, as you know, around integration. And integrated delivery is clearly one of the things that links to this. And the question for us as a board is, do we think that the direction we've set ourselves in terms of the priorities we've got, integrated delivery, and then are we now focusing on the right issues that are coming up in the system? And therefore, are you getting visibility at future meetings about what those issues are and what we're doing about them? So if, as Craig was saying, we've got a number of areas where we've got pressure points around accident and emergency 4-hour wait, around delayed transfers of care and some of the issues related to that and the financial thing. And because we need to make sure patient flow is happening, is this board going to be kept up to date with how that progress is being made, and then what the actions are being taken to deal with those on a regular enough basis for us to be satisfied that we've got them in place. As Craig has said, I think we've only had 3 meetings. They are fortnightly. So on Rob's behalf, I think I can assure everybody that there is a lot of attention being put on it. We are looking at the right things. And I would say we wouldn't be looking at these if we hadn't done what we'd already done around integrated commissioning and integrated delivery. I don't think we would be in a position to get into the level of detail we've got into and be able to be sure that we're focusing on the right thing. So I think as a system-wide approach, this is the right way of doing it because it's highlighting things. But this board needs to assure itself that we are focused on the right thing. And I'm just wondering from the perspective of the board and whether Sheila, from a clinical perspective, could just give the board assurance that these are the things that you would most want the board to be made aware of in relation to system priorities and system pressures at the moment.
Yes, I think. So thank you, Carol. Yes, I am a member of the System Improvement Board, so I have been involved since the beginning. I'm really pleased that the fragility of primary care is a really important part of that, because picking up what Ruth said, we feel that frailty impact in our surgeries, and you can deduce that actually we feel that more greatly, if that's the right way of putting it, than perhaps our colleagues in other parts of the country, because we have those populations. So that all builds to the impact, the inability to spend as much time with our patients as we would like to. The other key area for me is the safety and the quality and risk framework, and I think that's absolutely the right place to focus. And actually, I think the piece of work that's being done around that is quite innovative, in fact, in looking at the whole system risks. It's also quite difficult, I have to say, having been involved in some of those conversations, because we're all very used to thinking about our own quality risks as they present to our own organisations. So it's presenting some challenges, but there's a really goodwill to work together, and I think we are making progress. So to answer Carol's question, yeah, I would like to offer assurance to the board, and I think we are absolutely focusing on the right things.
Are there anybody else want to add anything? No. So I think really we take up, on behalf of the board, I think we do need these regular updates. So if we could have them on
Chair, through you. So, board, obviously you want to receive your regular updates, which we can arrange. I think if members are happy to agree that these are the correct priorities that this improvement board should be focusing on, then we'll pop that in the minutes also. Given that the improvement board's meeting on a fortnightly basis and this board meets on a quarterly basis, there is a good amount of time between meetings for you to receive updates. So Craig, if we could talk about how we might update the board on a more regular basis in between meetings to make sure everyone's clear on what's happening. Thank you, Chair.
I think we just need to be careful that we don't get updated about every meeting. What we're trying to do is looking at trend and impact, and I think there's a lot of complexity in this, both on how the system works, what it's measuring, and how we tell the real difference on the ground. So I think having the right scorecard, but actually that period of time gives us a real chance to see trends and changes. If it's too regular, we're dealing with the operation of the board, and that's for them to get on with. What we want to see is the impact that the board is making.
Okay, well, we'll rely on Ross and Craig to get together and make sure that everybody's kept informed. But I do agree with you, John, there is a danger that, a bit like when we started on the integration journey, if we were sort of like in there meddling too often, then it actually stops the board doing what it wants to do.
I'm sure we can trust Ross to make sure that it's all happening outside of the meetings.
No, I think this is your big moment.
Thank you. Good morning, everybody. There's a paper in your supplementary pack which just provides an update to the board on the work of the Children and Young People Partnership System Design Group. This sets out the origins of this group, which is essentially a merger of the Children's Partnership and the Children and Young People System Design Group. So we've actually mashed the titles together. We've made a number of changes this year to that group. We've refreshed the terms of reference and the membership and tried to reconsider how that group functions. The focus really is on support and challenge around progress in the children and young people system across Plymouth. So in your pack, you'll see on page 3, we set out as well where that group sits in the governance structure for PCC. There are 3 groups that provide updates into the partnership group. So there are 2 system optimization groups and 1 steering group, which report into each of the meetings. And we also take updates on the Children and Young People commissioning strategy and progress in relation to that, and any other relevant developments in the city. So for example, at our most recent meeting, our July meeting actually, we had an update on the partnership between the NSPCC and Children's Social Care around the prevention of child sexual abuse in the city. We had an update at the September meeting around Thrive. So we've had various developments, so the group is very much kept up to date. We've had 2 meetings since the refresh of the group, and we've got a much larger stakeholder meeting in the Guildhall this afternoon. I have a car full of tea and coffee and plastic cups. So if you see me dragging bags around the city this afternoon, that's what I'll be doing. There's a real sense of excitement building in that group around system change. Most recent meeting, for example, we had a discussion around the work around integration of community health, wellbeing and SEND. And the 3 providers, PCC, LiveWell and PHNT, were all in the room. And there was a really exciting sense of the changes and the positivity around integration to deliver better services for children and families. So that was really exciting to see. It's also becoming a really good place to test ideas, so draft commissioning strategies, anything new we want to try. It's a good forum. Jackie sits on that group, so I hope you find the same. Excellent.
It's really good.
Thank you, Jackie. The purpose of today really is we want to make sure we confirm the upwards reporting of that group very much in a similar way to the conversation you've just had, to make sure that we are being, as a group, appropriately challenged by the Health and Wellbeing Board to make sure we're delivering appropriately for the city.
Right, any questions or comments? None at all? Terry, I'm sure you got something you want to say.
I mean, I'm just delighted that it's all coming together now. I get regular updates on every aspect of what the plan is here, and it's just coming together and it's feeling good, and I just hope we can pull that final bit off, you know, and make improvements for children in our city. And we're certainly on target for it. We've got a good team supporting us as well. Thank you, Chair.
Jackie?
Well, I'll just put a couple more sentences around it. It's really good. It really seems to me it is a good example of how you can look at real systems change, and I would agree with you, Emma, that everybody is right behind it and pushing it, eager for new ideas, and it's one that we've been fully involved with and have enjoyed being fully involved with, and I think it's all very helpful.
Thank you.
So I've got the pleasure of chairing this group, supported by Emma and colleagues, and I'm just really pleased it's here today, because I think the Health and Wellbeing Board have not had sight of enough of the children's work, and there are a few of us around the table who are really involved in the children's world. And sometimes the adults' world can take over a bit because of the size and the amount of money that's spent and some of the pressures. And I think there are enough of us in this room that think if you get it right around children and young people, that actually we are really going to make a system change. What I'd like to hear really from the Health and Wellbeing Board is whether or not, in line with the direction we were set some 2.5 years ago, whether this now feels as though it's in the right direction. And I'd also like to see if Judith would mind giving you a bit of a update around SEND particularly, because I think you've got a bit of a jewel in the crown around the work that's gone on And I'm not sure your board has ever heard anything about that. And this is an opportunity really for us to showcase some of the work that's going on. But I would really like to hear from Health and Wellbeing Board members if you think we've got the direction right now and this is where we should be going.
Judith, over to you.
Yeah, I was going to come in anyway, and Carol's actually covered some of what I was going to say, which is you've certainly heard me say on several occasions that if you want to get the adult piece right, then in some respects you need a disproportionate amount of attention on the children's, and certainly some of those factors that affect people later in life are all emerging when children and young people are developing. I think the Children and Young People System Design Group is in a really good place. I think we're starting to see, after a period where we've been trying to form and establish what systems leadership would look like, that around all the priorities we've now got some really meaty developments. And one of the things I was going to say is that for me one of the exciting things is that each time we bring this kind of update you will see progress and you will see how evolutionary and revolutionary some of this can be. So even since we did this paper, there's another piece that can be added to this around what we're doing on the aspiration strand and the education board. So I think you know, if we can bring things regularly to the board, you will see the fluidity and the progress that's being made. So Carol also asked me to just say something around SEND. I mean, many of you will recall that when the Children and Families Bill went through in 2014 and the raft of reforms that came through that were first announced, it all looked like a huge amount of work for the system. And there was a point where I thought, gosh, how will we ever bite off all these pieces? And the key bits of the reforms were, of course, rethinking assessment, moving from the system of statements and how people had become attached to the idea of if you get a statement, you'll get the resource, you'll get the help, moving to a new system where education, healthcare planning is really done in conjunction with families. And I'm pleased to say that I think our inspection last year and the work that's gone on since then recognises that Plymouth's really got a good grip, a good hold on that system of education, healthcare planning, done with families, not done to them. Another strand of the work was us thinking about transitions, and we've now it's maybe still embryonic, but I think that we've got a good platform now to move forward with how people move through different phases of need and how we are agile with the way that we apply resource and again continue to work with families. And one of the good things that you can see from this high-level report is that one of the things we're doing is bringing parts of the system together. So another bit of the SEND reforms was the way in which we would look at integration, and we have now got health partners, social care partners, education partners and other stakeholders really round the table saying, why in 2017 do families still report to us at times that they have to move from one referral pathway to another to get what they need? And we're really, really tackling that now. And I think that piece that has been just outlined there around the integration programme that's going forward with a proposal for how providers can just get on with this, and then we look at the system changes. I think that's absolutely fantastic. Another element of the reforms was thinking around the provision we've got for education in the city. We've just undertaken an enormous special school review, looking at facts, looking at evidence, looking at myths, thinking about how we go forward on that. Very happy to bring that to the board. And then, of course, we've got the issue in SEND around how we actually do meet, the needs of young people with the most complex needs. And I think our system is very strong and resilient in that respect.
Thank you, Judith. You mentioned health, education and health statements. I would like some reassurance that it's not a capital E for education and a small h for health. I think they should be equal, both both have the same priority, because without one, you won't have the other. So if you could reassure me that they are sitting as equal partners, I would be quite happy.
Well, Clearly, Chair, I could give you some kind of verbal assurance, which is very easy to do. But I mean, we can also bring some data in that shows how the system works together to make sure that health and well-being needs are met as part of that plan that is done. They are all capital letters when you look at the acronym. They're all, the EHC is all capitals.
Much. I mean, I personally would like that. If you have some material, I certainly would like it. I'm sure the board would probably like to see it as well.
Just a comment, really. I mean, it's really pleasing to hear services come together in that way, because, I mean, I've been banging on for too long about transition between children to adult service, and obviously, from what you're telling us, yeah, you've really got. And I'll just recite an experience I had with casework, where parents came and they were really concerned about where their child would go, and absolutely, I can assure you that the service listened to the parents, and that child was placed where what was felt best for parents and children, not just the child in this case. So I think it is working on the ground. I'd be the first one to criticise if it wasn't, and I have done in the past, but I think bringing those services together, that's a real added value to our young people who have a really difficult time.
I think it's maybe worth reflecting as well. I've worked in a number of cities, and housing is obviously key to health and well-being, education. Having the right housing, the right facilities for children improves education. We don't get anything like the number of queries, concerns, complaints around how housing impacts on children's lives in this city than anywhere else. And I think that's because I know that my staff and other housing providers are integrated well into the system, and they come back and report to me regularly on how they're working closely to improve health, but education and children's lives as well. So I wouldn't want that to be lost with all the H's, because I think it is fundamental that children living in the right place to get a good start to life.
And I welcome your new initiative, a new home in a new year. I think that is going to actually help our children, our young people and our families as well. Judith.
It might seem a little odd to come back on Councillor Tuffin's comment and not just bask in the glow of, you know, the fact that you were saying you thought it was working well on the ground. But what I'm going to say is that I think we have things working better than they have done for some time, but it is still a priority area, because for many children and young people and their families, particularly the ones that had reached that point of transition before we probably brought in education healthcare plans, because, you know, with an education healthcare plan, we are looking now from the earliest possible point at how the family wants to see the transition happen, and that might be 10 or 11 years down the road, but we're planning much earlier. So I think what we still see is that it's not where we want it to be, despite there having been improvements. And one of the strands of the SEND work we've been doing is that we've been working with parents and carers, and this year developed a new forum so that those honest conversations can also happen much earlier and in a good place to help the whole system plan. Because it's tricky, isn't it? The children's system and the adult system are really different. And if you don't work hard, both at system level but also to an extent with the individuals, you're going to get that disconnect. So I appreciate that you feel you see improvement, but it's still a priority area for us.
Thank you for your honesty, I think. Anybody else want to? Jackie?
I'm sorry, it's just another thing on really good. I think what you've just said, Judith, about building on and having a forum and building on what children and parents want is one of the things I'm saying is really good about this. I think there's a genuine looking at what people need and basing it on this. The other thing that I'm thinking is really good is you're not thinking of it as pure agency provision, that actually people live in communities, how well families function, how well children function is a lot to do with their communities and the strength of those communities. And I've welcomed the way that that's been built into this, and also looking at what co-production actually really means, and planning in a forward way how we do some joint workforce training between the community and agencies on real co-production with families. So that's another bit of really good.
I think we would welcome regular sort of like updates. We've sort of like highlighted some of the challenges. If we can sort of like start seeing some is sort of like work going on through that. I mean, it sounds really positive, but as a board, I think we really need to sort of keep, and I do agree with you, I don't think we have focused enough on children and young people in the past, because although they're with you sort of like for a relatively short period of time, they very quickly become adults and then they're in the system for a lot longer. So I agree, we need to start at that early stage to hopefully sort of like iron out some of the issues along the journey. Thank you. I think, Ruth, it's over to you now.
Thank you, Chair. Thank you, everyone. I'm really pleased to be able to bring to you today the Director of Public Health Annual Report. It's the first annual report that I've written. As you may recall, I've been Plymouth Director of Public Health for just slightly over 12 months now. The role of the Director of Public Health is slightly free rein to write an independent report, and it is very open to interpretation on how that is written, what choices are made. Typically, it can be used to challenge the system, to say there's a problem that nobody's paying enough attention to, and therefore I'm going to raise that point to you. I feel that in this system, we are well aware of our challenges and we are working together very closely to tackle those. And so the approach that I've taken instead is an asset-based approach. It's to say, we have some challenges, we are trying to tackle them. Let's celebrate some of the work that we are doing to tackle them. So as members around the table will be very well aware, we have a 10-year plan in Plymouth to tackle health inequalities, Thrive Plymouth. And Thrive Plymouth is recognising that all of us across the city are partners in trying to tackle health inequalities. It isn't within the remit or within the ability of one or two statutory organisations to do this. This has to be around everybody taking a role in it. As Jack has mentioned before, people live in communities. Everything is important in terms of helping to tackle health and well-being, and there are a very wide range of determinants that impact on health and well-being. And so through Thrive Plymouth, we are helping to pull together a really wide range of people to do that. And in year one, we focused on workplaces, because obviously people spend a considerable amount of their lives in the workplace, and that's an opportunity to influence their health and well-being. In year two, we focused around schools, and this is the topic of the DPH annual report for this year, is looking back at what's been done, not just over those 2 years or over the year of Thrive Plymouth, but what are the good things happening in schools that we should be celebrating, but more importantly, that we should be helping to sustain and that we should be growing. We know very well, and that's already been mentioned today by the Chair, that healthy children and young people tend to not only feel better, but also do better in school, in education. And we know that then has a lasting impact on their lives, on their chances of having healthier lifestyles, of remaining well, and living longer lives. And so we really can't overestimate the importance of school, both as a place to learn, but also as a place to live and to live healthier lives, and perhaps be exposed to healthier options than maybe are available at home. So schools are a very key asset to us in our city. And I'm really pleased to say that many of our schools have been engaging with the Healthy Child Quality Mark. There's been a commitment for very many years to help schools to promote health and well-being of their children. And this is something that isn't necessarily widespread across the country. And so the year of Thrive Plymouth was pulling together work already done, and we're certainly not trying to take credit for that. My report, I hope, makes it really clear that this is about celebrating the success of a very wide range of people that have put into that. So we've put in this report some examples, some case studies of the work that has been done under the Healthy Child Quality Mark, some examples of schools where they've been able to increase physical activity. They've been able to perhaps help to promote smoke-free environments for children at home. They've been able to look at the types of foods that people are eating, the diets that they're having during the day. And also overlapping with Year 1 of Thrive Plymouth around helping schools to be healthier workplaces for staff as well. Staff are also a vital asset to schools. We also present in the report some survey results. We carry out surveys in schools every 2 years, and that helps us to keep an eye on what is going on around some of those healthier lifestyle behaviours. And as you will have seen in the report, there are some positives there. But there are also some areas that we still need to do more progress on, and things like healthy eating, where we're seeing that the proportion of people eating more healthily, eating their 5 fruit and veg a day, for example, is not as high as we would like it to be. We've got room to improve, and there's also concerns around mental well-being that you can see the survey flags. But on things like drinking, smoking, and moving, we are doing very well, and we're seeing positive signs. I'd also just like to highlight to the board some fairly recent intelligence which has actually drawn a little bit of attention to Plymouth. We know that childhood obesity tends to be associated with deprivation, so more deprived areas will have higher rates of childhood obesity. And indeed, at aged 4 and 5 in Plymouth, we do have a slightly higher rate of overweight and obesity in our children than the England average, which is probably what you might expect for the population. But the really interesting news is that by the time our children get to 10 and 11, where they're measured again as part of the National Child Measurement Programme, they are now coming up as either as equal to England or this year better than England. So there's a question being asked nationally actually about what are Plymouth doing that's so good, and are we really bucking the trend? It's too early to be absolutely categorical and say that we are, but these are really promising results. And we know that tackling things like childhood obesity, it is not, as I said earlier, it is not about one partner doing something really well. It's about a whole system approach being taken, but encouraging news nonetheless. So I just wanted to share that with you. As I just mentioned, the report signals the importance of mental well-being, and I'd like to then link into the fact that Thrive Plymouth Year 4 was recently launched and is focusing on that as a very important factor. We know that the lifestyle choices that you make are heavily dependent on your well-being at the time, on your mental well-being at the time. And similarly, it's a virtuous circle. Similarly, if you are making those healthier choices, you're likely to have better mental well-being. So the two go hand in hand there. And so we want you to celebrate the work that's been going on in schools. We want to help to focus attention on that and to make sure that the focus is kept on that work. We don't want this to slip off the agenda. It is extremely important. And that was really the purpose of the Director of Public Health Annual Report, focusing on that. So in terms of the other side of this, as I've said, we focused on a very asset-based approach in this report. We know there are challenges around child health, and those are being monitored and being looked at. And so I wouldn't want to sit here giving you the impression that everything is absolutely fine, but I hope that the report highlights some areas where we are doing well, we are doing all the right things, and what we need to do is to carry on doing those. Happy to take any questions or comments, Chair.
I mean, children's mental health is really important, and I don't think we sing our praises here in Plymouth enough about the work we do on children's mental health in our schools and to improve the lives of our young people's mental health in the city. I constantly bang on about how good we are, and I've been invited to go and talk about it at a conference next year. So, you know, Ruth, I'm grateful to what you've done and the work that you've put into your report, particularly focusing on the area of children and young people in our city and improving their lives. So thank you for that.
I just wanted to congratulate Ruth on the report. I found it really enjoyable to read, and it's not often you say that about the sorts of many reports that we read. And it's lovely to see all of the successes celebrated. There was just one thing that stood out to me, which is not local, it's more of a national thing, and it's around the alcohol. It did strike me that, you know, with that figure, why do we have a legal drinking age of 18? When we see so many alcohol problems deriving from people taking up drinking alcohol under the age of 20, just made me think, really. But no, well done, Ruth.
Very quickly. Yeah, well done, very good report, Ruth. Very welcome, particularly focused on young people. I think it's important to remember, I'm aware that public health had to deal with cuts, but they're still very focused on the preventative agenda, which I always think we'd be so foolhardy not to concentrate on the preventative measures, because that's where we'll make an impact. Sometimes we find ourselves just dealing with the effect rather than changing the methods. So I think it's very welcome, and I'm really pleased to see that this 10-year programme is carrying on, because I think it's really worthwhile. And I think you'd be congratulated, because I know how difficult it is with shrinking budgets, and I know public health in particular has been hit by them, but still carrying on this preventive work, you need to be the whole team needs to be congratulated.
Again, I do think it's a great report, and I think Thrive is a great initiative. It really focuses everybody in onto the right things. I do think, though, we still have to note that under moving and mental well-being, we've gone down, and I think we just need to be clear around where we think that issue is and what we can do collectively, so that we do focus in on the right things, because it's easy to congratulate ourselves in the 3 areas where we've done fantastic, but there's also a real challenge for us. And I know we're moving into a period where we're looking particularly at mental health and well-being, but we just can't forget the fact that those two indicators are going slightly in the wrong way, despite all of the good work that we're doing. So collectively, we just need to think about how we address that in the coming year and beyond.
Okay, John?
Yeah, again, I reiterate the comments already made in terms of the report and the way it's presented and everything. Very, very, very interesting the way it's done. One key thing that I'm really keen to understand how we're doing in Plymouth is drug usage within school-aged children. It seems to be a real gap in our collective understanding of what's really going on. I understand the reticence behind people wanting to disclose information about that, both the children and the schools themselves. But I think it makes it quite challenging to anticipate what the future picture is as those school-aged children grow into young adults and so on, in terms of what that drug usage is. So I don't know if there was anything you gleaned from conversations that you've had already, or if not, whether any future surveys or conversations are likely to uncover that. If they were, I'd be really interested in what that came up with.
Thanks, that's a really interesting point. I'll go away and have a few conversations about what we might be able to do to try and unearth some of that. I don't believe we have data at our fingertips, but we'll see if there's a way to do something around that. Thank you, it's a good point.
Thank you. And yes, I think like everyone else, really enjoyed the report. And whilst I'm very close to a number of aspects of the work, that it was good to see it all in one place, because it does become compelling. I think the challenge that remains for us is that with a very different school system going forward, then the collaborative efforts and the profile of children's health and well-being that you see reflected in this report, I think there are challenges to us around sustainability of that collaborative approach. And I think that one of the things going forward is for us to use this as a baseline. If you think about the funding, the historical commitment that's been made to things like the school sports partnership, the buy-in from schools to the Healthy Child Quality Mark, the even junior life skills, you know, that we see the amount of schools purchasing that, reducing. I think that there's something that I'm thinking about how we use this as a baseline and then actually keep the profile up, because if we just say this was a point in time, I think in 5 years it'll be really different, because our whole school system needs to understand that this is a very powerful statement we're making here about collaboration in Plymouth.
Yeah, you're absolutely right, and we're really obviously working with you around that. Really welcome any suggestions on how we can help to take that forward and to make sure we are trying to embed it.
I might be getting slightly off piste here, but there seems to be a theme there about drugs and alcohol with children, about keeping up some of the sporting activity, working together. And I was thinking back to what had been said about the NSPCC working together with childhood, and they again are looking at working collaboratively. Now, what they're saying about the prevention of child sexual abuse, I think is very sensible. They're saying that actually what we need, and St Luke's are saying this about death and end-of-life care as well, and various other people are saying it about other things. What we actually need are communities that are open, that are talking about these things, that understand that their children need exercise, and are prepared to talk about where they see the children taking drugs or where things are happening. So I know this is a long-term thing, but it seems to me in the preventative long-term, we need to be thinking about, and certainly in the voluntary and community sector, we're thinking about how do you build those strong local neighbourhoods where people are prepared to take care of their children by talking about child sexual exploitation, by talking about drugs. So again, long-term preventative, and I know you're talking about short-term agency and budgets, but I felt those three things pull that together, and it's something we could be working with you
on. Just the same as everybody else, I think Ruth's produced here something that's really easy to read, and it's nice to see it so colourful and presented in the way that it's been presented. And I think the two items we've just had, linking together, demonstrate how much emphasis there is on children and young people, and we should be rightly proud of a lot of the work. But I'd just like to remind the Health and Wellbeing Board that as well as all of this preventative work and the fantastic things we've been talking about, we are seeing amongst our most vulnerable group of young people real difficulties in terms of, and this is mainly in my social care world, much more difficult to find placements for those young people with very, very difficult and complex needs, with probably some very difficult behavioural aspects that we're trying to deal with. Some of those are related to some of the things Jackie's related to, either sexual abuse or drugs and alcohol or domestic abuse and long, deep-rooted things within their families. And I just feel that the board needs to be aware that in terms of cost of placements, that's the most difficult thing I'm dealing with in terms of the budget situation, but also the difficulty sometimes in finding the right placements, and the work that we have to do with Live Well and Derriford around some of the young people that often end up using their services, where we are all working together to find the right placement, and some of the work that we do with Dave and colleagues in the police around some of those children with very, very complex needs, we mustn't lose sight of. So whilst we are all celebrating all of the work that's gone on in here and in the previous report, we've got to make sure we don't lose that group, because it is that group that are probably causing us the most angst in the system around money and how we place. And we've, on the positive side, we've just done a really innovative foster care recruitment campaign to try and bring more carers into the city. And we need to do more of those sorts of things, because some young people will always need placements. We will never eradicate that completely. And anything we can do as a panel to make sure we've got a focus on those things is really helpful.
Are there any other comments? I think what we need to do is to actually approve Ruth's annual report. Are you all happy to do that? Yes. Thank you. Right, on to agenda item 8. I think this is Carol and Craig again. This is the update on the organisational design.
That's me then. I'm not handing that one to Craig right away. So I'm going to start, but there are other members of the board who do go to a number of the STP meetings. So when I've done a brief overview, if any of them want to contribute, that would be welcomed, I'm sure, by the board, because I think the STP, and we've had several presentations here, it's sometimes quite difficult to work out how this Health and Wellbeing Board relates to the STP. And a number of us sit in meetings where we're looking at how do you change the whole of the health and care system for the whole of Devon, including Plymouth and Torbay, and what does it mean for us as a board? And I welcome this report, which has actually been done centrally by the STP team, to try and keep a regular update into all of the governing bodies and boards that operate across Plymouth, Torbay and Devon. Because I think it's been long needed, where there was something that everybody could just pull out of it, what was happening currently. So if I just highlight a few things from it, I think probably one of the most important things to understand at the moment is that as an STP, we're going through a period of a new recruitment. So Angela Pedder came to the last STP update on behalf of the whole of the STP. She's now retired, and what's been decided is that there is a recruitment for a single STP chief exec, as well as the accountable officer for the 2 CCGs in Devon, which is the North East and West Devon CCG and South Devon and Torbay. So there will be one single person, and you've got in the report the recruitment process for that, and that is well underway at the moment. And again, people from around this board will be involved in some of the recruitment processes. But then we will have somebody who is covering the whole system, the STP and the 2 CCGs. At the same time, Dame Ruth Carnell, who's led us through the initial stages of the case for change and developing the initial programme, is due to stand down at the end of March. And so there is a process underway now to get a new independent chair for the STP. And we'll keep you updated about how that progresses. The second area was around the acute services review, and you'll find in there what's happened during phase 1 and what steps are underway around phase 2. I think the thing to highlight here is the mutual support agreement, which is about how the 4 acute trusts in Devon will work together to mutually support each other around workforce. You will hear constantly workforce issues. You've already heard Sheila mention the primary care workforce issues. There are some disciplines within the acute services which are also difficult to recruit to, and this will enable people to actually support each other around some of those difficulties. So that's really important. And then the other area I will highlight is under 3, we're looking towards moving to the organisational design for the whole system, and for us to understand that we're looking at how do you get a strategic commissioning approach for the whole of wider Devon, but also what will be the approach for the Western system which Plymouth sits within. And that's at its early stages at the moment, but there is an absolute commitment to build on the integrated commissioning approach that this board has driven and the integration around delivery. And we've got a number of us involved in shaping that going forward. So again, I think that's really important. And then finally, I'll just pull out on item 7, the priority work streams. I think I said at a previous meeting that I think you will find from the priority work streams there, they link to all the things that this board has said is important. You've already heard this morning about prevention. We're talking very much about the children and young people, but it also highlights mental health and integrated models of care, and all of those are really important to us. So I'm happy to take any questions, but I will probably also rely on people like Sheila and Ruth and Steve, who sit on numerous boards with me, so that if there are any particular questions, we may handle them between us. Thank you.
Something that I would like to ask, when we have like one system with one budget, will that actually mean that Plymouth gets a fairer slice of the cake?
So I'll start, and then others may want to join in. But there has been a piece of work done through the STP to look at the funding equity across the whole of Devon. That has highlighted that Plymouth needs a higher share of the overall budget. The difficulty the STP has got is how do you move money around the system, and how do you allocate savings that may be required in a way that brings that equity about. And at the moment, I've not seen how that will happen next year and the year after and the year after that, because at the moment we're going through the process of setting the budget for next year across the health sector. When we've got that information, we'll make sure that comes to the board. But I don't know if any of my colleagues have got an update that is further than I've got.
I don't think I can give an update, but maybe just a bit of clarification, really, which is that whilst I would say there is an acknowledgement that Plymouth and Western locality doesn't get its fair share, there is also the acknowledged difficulties of rectifying that, and we're not going to get a cheque written for us anytime soon. I think that's fair to say. There's also the context that all of us are spending more. Even if we had our fair share, we would still be spending way above that. So the expectation is that we will work towards living within our means, and that part of that process will see over a number of the next few years some, if I say indirect reallocation, it will probably indicate to you that none of us really know how that's going to happen yet. But it's an intention without any implementation plan at the moment. But what I can say is that those of us that are on the governing body are pushing hard. I'm looking at Ruth, who supports me in this. You know, we really do think it's really important, but we do acknowledge that we are also spending out of our means, as all of us are.
Just to recognise the point that you raised, Linda, is one that Healthwatch has raised in a number of the forums that we engage with the STP. But having said that, we have to recognise the issues that Carol and Sheila have very articulately outlined in terms of the challenge, not just for Plymouth, but for the whole system, and the whole system being Devon. But I want you to rest assured that it is something Healthwatch has acknowledged. Interestingly, our colleagues from Healthwatches in Torbay and Devon also acknowledge that and support that view, which is good to know. But it is a point we'll continue to make, but we shouldn't forget the overall challenge that's been outlined, and Healthwatch does work in that realistic way.
Thank you, Chair. Yeah, but I need to remind myself of why we went on this journey, because I remember some time ago we all were looking at the unfair distribution of health in the Plymouth area, and we seen this as a way to actually address that. And now we're being told that we may be there, but everyone else may have to come down and meet us, which is disappointing, I must be honest. But I think the important thing is in a time when there's no extra money coming in, I do understand savings have to be made. that's important for us to keep an eye on health outcomes equalising. Obviously, I would like lots more money, but that's not going to happen. But I also think it's important that we had a cross-party agreement to support the STP, and I think that was a really positive move forward, because not every authority's done that. A lot of authorities just seen it as a way of kind of kicking the shortage of money, and I totally understand that. And, you know, I've had problems justifying this decision to other people, because they say, oh, I should only worry about Plymouth, I shouldn't worry about Devon. But I do understand the concept now, but I must admit I'm disappointed that it's kind of evolved. Rather, we weren't aware of the direction we were going at the beginning. We may have been told, not understood. But it is disappointing that health outcomes may suffer in other parts without us having an improvement. So, I mean, I think we need to keep an eye on that, and we need to be kept aware of that. And at any point in the future, if we think it's not working for the people we represent, then we make them claims. But I think it's very positive that we went forward with this, and the difficulty I always found with a council is we're having to understand a load of health issues that in the past we wouldn't have been concerned with. But I think that's, once again, that's very positive, and I think it's very helpful that we can see the bigger picture. But it's not always going to have the result we had hoped for. And I think in some ways, when it evolves and changes, it's not only disappointing, but you know, you have to question your own reason for embarking on this in the first place. But I do understand, you know, I would rather see this a 10-year plan rather than a 3-year plan, because I think the cuts are obviously eye-watering. And I feel I have to make these points because I think they're important, because the people that I represent would expect me to make these points. And they would be extremely disappointed, given some of the wards in this city really do suffer from bad health outcomes. Thank you.
Thank you, Joe. Just picking up on Ian's points there, I think from Plymouth and Western locality perspective, I think the engagement with particularly elected members cross-party of the understanding of health and care and other issues has really helped to shape some of these discussions. So I think that wider involvement and understanding is really useful for Plymouth in particular, but also the Western locality. Just to add to some of the discussions that Carol has covered, so the acute services review has been quite extensive. There's been a fair bit of publicity around that, but there are significant work streams that if as an STP we don't resolve, so workforce in particular, for a variety of sectors. So we touched on primary care. Nationally last week, I think psychiatry was saying there's a 10% vacancy for psychiatrists across the UK. So how we tackle some of those workforce issues is going to be a system-wide, county-wide, peninsula-wide agenda. So there will be opportunities for us to shape that agenda, but also I think increasingly how we deliver and how people receive those services needs to be a very clear dialogue with what the future shape of that service delivery will be like. So it is an ongoing discussion, but there will be changes to workforce because it's the demands are driving us that route. But I think what we have got is some very clear learning that we can help shape that agenda in looking at our future health and care wider workforce.
Thanks. If I could just address a couple of the points raised by Councillor Tuffin. First, to give assurance that our health outcomes, we are very well aware of that gap and monitoring it, and it is a regular conversation that I'm engaged with within the STP as well. It is recognised Plymouth's poorer outcomes around health. So whilst we're not happy that the gap is there, we are very well aware of it and looking at it. Also to say that one of the issues we have here is that we have a lack of demand for some of the services that we actually know people would benefit from, and in other areas of the STP, that demand is there and is utilised. And I'm aware of conversations going on at the moment. I'm a member of the clinical cabinet of the STP, and there are conversations going on around how would services better be designed so that the people that get them are the people most in need, with a really clear remit to make sure that we are tackling health inequalities in those decisions. So whilst I'm not trying to put a rosy spin on everything, just make it very clear that health inequalities come into every conversation, and I certainly see it as my role to be active in that conversation. And finally, just a point around what I see around integration in Plymouth and what that's done for us. And it is true that the pocket of money is shrinking, but the way we use it is changing, I think, and the way we are able to look at the money across the system rather than keeping it in our little silos and saying, well, I can't possibly contribute anything to that because it doesn't fall within my remit, or I have to take all of the cuts off this because my budget's shrinking, means that we are seeing services designed in a way that, shall we say, makes the least impact of the reductions that we're seeing. So that's what I see that the benefit of integration being. Completely accept many of your points around the fact that we would love to be going further, better and faster and doing more, but I think we are making the most of the situation that we're in.
Thank you.
I think what I'm looking for from the board are any recommendations or any suggestions to take forward on this. Over to you.
I thought the report that we received was very informative and quite articulate and also very accurate, which is helpful. And it'd probably be helpful to ask the new emerging STP team for a regular report that we can receive and be fully updated. There's just one other observation that I would make, being part of the STP system, with regard to how Plymouth fits into the overall system. And at times I felt there's friction there, but on our overall point of view, some of the initiatives that I see taking place in Plymouth, and there's a lot of references made to integration, suggest we're not only keeping up with the game, but in many cases actually ahead and setting the scene for what's going on elsewhere in the county, and I think that's worth sort of acknowledging and noting. But in response to your thing, I think a regular report from the STP team to this board would help us be fully au fait and up to date with what's going on.
Thank you, Chair. No, I was going to make the same point that we need regular updates because although I am a little bit negative at times, but that's my nature, I'm afraid. You know, I do understand and do appreciate the amazing amount of work that goes into solving some of these big ticket problems that we got in health.
Yeah, I thought, again, it was a really good, clear report. I guess the thing for me that would be useful as we're going forward is it's such a broad area and a broad subject, but it would be good to see where we sit within some of this, specifically within Plymouth. So we know we're part of that wider, and actually I think it's absolutely fundamental for the city that we're involved in this, because we're only going to get a fairer share by being part of something bigger as resources shrink. The clarity we have on our position is really helpful. So I think some of the other reports have made it very clear where we sit within Plymouth and what our challenges are. But it would be good when we're looking at this report to understand where we sit in relation to others, because that helps us to make the case on a regular basis.
I think that's helpful, John. I'm just wondering whether, I know Craig's going through the process at the moment of looking at how the plans that we're delivering for Western link to the priorities of the STP, and whether we could work out the system so that we bring our regular updates alongside the STP updates, so that this board can see what's happening at the strategic STP level, but also what we're doing on a local level, because there are some examples of things that maybe sometimes we're getting some funding that comes in to do something. And I'm thinking of things like some of the mental health work that Steve's been able to develop some new things on the back of some money that's become available They're enabling us to do things that we may not have been able to do if that money hadn't become available, and whether we could do things to keep the board updated. Does that make sense?
Go on, Steve, says Craig. Certainly, Carol, we will be delighted to work with you on that. And I think there are some real practical things that, by working together, we are bringing more money into the Plymouth area on a number of levels. And a conversation, just linking back to Jackie, Jackie and myself, John Hamlin and Olivia from Mind got together this week. And just by us meeting, there was an opportunity to bid for money that we wouldn't have been able to have obtained for the city, looking around getting people into employment. So there are lots of opportunities, and we've got lots of evidence of where we've been able to work on that, and particularly within the mental health field. There is new money. We have spent it differently to perhaps how traditionally we would have done, but I think the benefits of that are now being seen. So yes, very happy to support Craig and yourself in that.
Yes, just adding to that, extra bits of money coming in, and Steve mentioned one there, but there are quite a lot of extra bits of money coming in that certainly would attack priority 1 in the plan here. So I think you probably all know that as a VCS infrastructure organisation, Esme Fairbairn have just given us 1.3 million to help change in the city. Rank are thinking of match funding that, and there could be other match funding coming in. So, you know, that's philanthropic money coming in, which releases people to do things like we're thinking in terms of a compassionate city. And I was going to say this to you later, possibly in work streams for this board, that if we could badge Plymouth as a compassionate city, then we could be doing a lot of things that build up those neighbourhood communities, that get things working, that slowly build in the preventative agenda. And I was thinking there's work going on already in that, and I was going to say that to you under the CCG, under the CQC inspection plan. There's sort of new work going on that's not reflected yet, I think. So, for example, St Luke's are doing a compassionate city thing and have been for 2 years, working on end-of-life care, wanting communities to talk openly about death and dying, and being neighbourly about supporting people when they are dying, talking to them about it, supporting them. And one of the this is about kinder neighbourhoods, but one of the impacts of that is likely to be more people dying at home rather than in hospital, people being kept in their homes rather than hospitals. So that's just one example. A much smaller example, Whitley has got £1 million for the residents of Whitley Big Local, for the residents to spend, and it's fascinating watching what's happening in that community once it's got some resource. So on the older people, and again I go back to the inspection, they started a bit of a do for older people, which was great fun in the pub and had lots of entertainment and stuff, and people play the guitar and all sorts of things happen, you know. Yeah, no. And then the younger group split off and they formed the Nifty 50s, and then they decided, all these are sort of isolated people who've been brought together, then they decided they needed transport to get to these things, so Whitley Big Local bought a bus. So now those people from, you know, those isolated elderly people now are running the bus, and a woman from the cafes administering it, so they go on trips, and they're now talking about holidays, and they make money by if people want to go up to Twickenham for a rugby match, they do charge commercial rates. So I mean, these are just all little pockets of things that are coming in on philanthropic and grant money that somehow we need to be linking up and knowing about. Why did I get started on this? Did Steve say something? Yeah, no, Steve said something about the other pockets of money and things that are going on. So, yeah, I was just telling you some.
I think that seems quite a good idea. Carol's suggestion that we have the 2 reports, and perhaps we can capture it in the local report, so like some of the things Jackie's talking about in Steve, because I think that would be really helpful. Everyone happy with that? Yeah, Craig could do it for us.
Another development opportunity.
It's good for you, Craig.
One other thing, thinking of Craig, social investment, there is a Devon-wide bid for some from social investment bonds to support social prescribing in communities, which Craig knows about. These are other possibilities.
On to agenda item 9, which is in the supplementary pack. And that's back over to Ruth, and I think Candice is going to ably assist you.
Yes, thank you very much. And thanks to Candice for joining me. Candice and Rob Nelder from the Public Health team, who you'll know has led on pulling together the report that you see before you, and it is very much hot off the press, hence why it was a to-follow document. So just to remind you that the Healthy Plymouth section of this report was seen by the board around 6 months ago, I think at the meeting before the last meeting. And that comprises the official part of the Joint Strategic Needs Assessment. But the report that you have in front of you today has been very much aligned to the Plymouth Plan. So it covers all of those topics that are covered within the Plymouth Plan to give an overview of what is happening in the city of Plymouth. And really this report tries to not simply be a compendium of data. It's not about just giving you numbers. It's about trying to give you some understanding and some analysis of what's going on behind the numbers. And some of the benefits of this report are not just the document that we've arrived at, it's the work that the team have gone through to pull this together. So we've brought together a range of different professionals with different types of analytical skills and other knowledge to sit down together and actually produce a report which is actually very diverse and covers quite a very wide range of different types of information. And these people would not necessarily sit down in a room together, because often you're very focused on your own work and your own topic and just looking at the information that is most relevant to you at the time. But obviously we know from the health and wellbeing point of view that all of these wider determinants of health are critically important, and so it feels absolutely appropriate that we now have an updated Plymouth report that reflects the work that we're trying to do in the Plymouth Plan, and helps us then to dive into it and to ask some of the questions around what is the data telling us about these issues? Where are we? Are we improving? Are we declining? Are there areas that we need to be concerned about and paying attention to? And so the report doesn't pretend to be the answer to all of our problems. It is almost a starting point, really. There's a constant cycle that we go through, isn't it, of what's the problems that we're facing, what are we doing about it, and then looking at whether the things that we're doing are working, and then going back into that cycle of, so what do we do about it? And this is part of that cyclical process. So, as I say, within the report we have a section on Living Plymouth, which focuses around the geography and the population and needs from the point of view of the neighbourhood, so looking at community cohesion, transport, the environment, crime, deprivation, education, housing. We have the Healthy Plymouth section, which almost speaks for itself and which you've previously seen. And we have Growing Plymouth, so around employment and jobs, wages, productivity, innovation, labour, all sorts of really interesting things in there that I must admit I don't typically spend a lot of time looking at, but I know are really important to what we're doing in Plymouth. And then the final section highlights some of the challenges and concerns. And these are areas that I think we probably want to be very mindful of in this Health and Wellbeing Board, and potentially asking ourselves the question of whether we feel that those are being adequately addressed by the city as a whole. My first look at these challenges and these concerns, I felt that these were no surprises here. These were areas that we are aware of and that we are looking at, which is obviously very reassuring. Doesn't mean that we couldn't be asking questions, and as I say, feeding into that circle that says, and are we doing enough, is the more that should be being done, and obviously assuring ourselves that the information is being used in the right way. With that, on that comment, I think, Candice, can I hand over to you? Is there anything you wanted to add, or anything particular around what we recommend would be happening to the report?
It's the first time I've used these. The only extra thing I wanted to say was that the Plymouth report doesn't replace the needs assessments, the more detailed needs assessments that sit underneath it. And the report is more valuable in an electronic format because you can click into those various documents. So the JSNA suite of documents still exist. This was an attempt to bring that together in a way that enabled professionals to see analysis in a cross-issue way. It was a really difficult piece of work to do. A number of you around this table were involved in helping us to set that narrative. And what we found was when you put a range of professionals from different backgrounds in a room, we speak a different language, we use different terms, and we also approach things in a very different way. The growing section couldn't be written by someone with a health background and vice versa. But that was really useful for us to know that different terms are used in different ways, and that might be part of the reason why some of the cross-cutting issues and the way we address them haven't been as successful as we would have liked to have been. In terms of the use of this document, I don't think we achieved everything we wanted to, but we're very happy to have a document that is a first stab at bringing together a cross-issue analysis. In relation to the Plymouth Plan, what we would like this to do in its annual review is to align very clearly with the high-level outcomes identified in the Plymouth Plan. It doesn't quite do that yet, but that's a piece of work that we definitely want to happen over the next year, so that the annual review of the Plymouth report directly enables us to find out whether or not the Plymouth Plan is delivering as it should be. That's in addition to the range of performance activities and monitoring activities that need to take place as well. There are a number of areas that we also need to address, and I'm hoping that partnerships like the Health and Wellbeing Board will help us. There was a lot of missing data, or data that wasn't of good enough quality for us to know if there were trends or if there were problems or concerns. That we want in future editions of the Plymouth report to focus or deep dive on emerging trends and issues that either partnerships believe might be something we want to look into proactively or reactively. That there is a group of professionals now, we want to extend that to outside of the council as well, that could come together and work in a community of practice in that approach, that could really take data and apply it to the direction of the city. That's an offer, but also we're aware that we don't want to stay in our own bubble. You have a set of data nerds and professionals that are passionate about analysis, and I would encourage partnerships to use that. And also the last role we want the Plymouth report to play is I suppose a challenge back to the Plymouth Plan of areas that potentially haven't been captured, trends or concerning areas that we believe that decision makers in the city might want to have a look at in more detail. We want to be that resource to bring those to the attention. But I hope that you find the report useful, and we would value any feedback that you have, either positive or negative. It hopefully will all help to strengthen the document in the future. Thank you.
Yeah, obviously my eye is immediately drawn to the crime section, as you wouldn't surprise you to hear. Yeah, I mean, very good sort of overall picture, I think. It is a useful picture to say. The only thing I would add, and this is no reflection on the report writing whatsoever. It's more a reflection on the change in crime we've seen in the last this year really, and of course the report won't have had a chance to catch up with some of that. But the significant increases that we have seen in many types of crime this year might, when this is refreshed, might give quite a different picture, particularly, you know, when you look around domestic abuse, violence, and violence without injury. Sexual offences, I think, already in there shows an increase, but there is a significant increase, you know, even in the last few months, and referrals to the SARC and various other things. So I think it's a really well put together report in terms of giving that overall picture. But I just wanted to add for the board's information, really, that in the last the last sort of 9 months, the picture around crime recording has changed significantly, and there's a variety of reasons for that, which are relatively well cited already. So.
Yeah, again, I think it's a great report. It's good to see all the information pulled together. I guess, interestingly, from the comment that David made earlier, not as much information around alcohol and drug use as there is in other areas. And is that because it's in a JSNA or because we don't have as much information? I guess the two things that jumped out at me, because they have a real impact on communities' health and well-being, particularly mental health, is the increase in levels of homelessness and the increase in levels of hate crime. And when we've got this focus around a welcoming city, and we've got a really good planning housing department within the council and some providers, it's what do we do more around those areas, because they have a real impact on health and well-being across the city.
Thank you, Chair. I was looking at page 19, and there's a statement there. It says, of the 30 indicators presented in the 2017 Public Health England profile, Plymouth has 10 that are significantly worse, and in brackets red, compared to the rest of England, and that includes the breastfeeding, under 18 alcohol-related hospital admissions, hospital stays for self-harm. So I'm a little bit perturbed by what I read there, and wanted to know the breakdown of all of that and exactly what that means. But the overall report I found was easy to read, and it's a good report. But can somebody just clarify what that reflects, please?
Yes, happy to. So the public health outcomes framework has a really wide, diverse range of indicators, and that's what this is referring to. And yes, it is. I mean, when we talk about the fact that we have this increased deprivation, we have poorer health outcomes, a lot of this is reflected in the fact that, you know, as you say, a third of the indicators are showing red for Plymouth. We review this whenever there's new data, and we have plans that explain what is being done about it across the system. So very happy to obviously bring those to your attention, but also perhaps that's something that the Health and Wellbeing Board might want to have a more in-depth look at. Very happy to do that and bring a report on that. We monitor, I mean, I suppose I should say, of course, that comparing just to England doesn't necessarily reflect our population. So we also compare with our nearest statistical neighbours as well, and that brings us a slightly different picture, and we can bring both of those to this board if that would be helpful.
Chair, it'd be helpful for me because it was just a worrying statement, just that particular statement within that bullet point within this report, and I would be very interested to look at that a bit more closely, please.
I think we'll take Ruth up on her kind offer. Is there any question?
I seem to have missed out on this paper. I haven't read it, and I don't think I got it, but I will look forward to it and read it with interest. So a very general comment, that the Plymouth Plan was done in consultation with the people of Plymouth. So when you say, Candice, that to get outside the bubble, yes, I think volunteering community sector and the work we did with consulting people of Plymouth, we would be really eager to be in on reviews. And indeed, we've tried various ways of reviewing the Plymouth Plan and having think tanks, which have never worked. So if you're convening one, we'd love to be part of it.
Sorry, I'm thinking. I think now I agenda item 10, which is Carol and Craig. This is in the main pack.
So that'll be Craig, Chair, just to clarify.
Another development opportunity. Yeah.
So within your pack, Chair, you will see a presentation that we've done previously on the CQC review. So I won't go in huge details, but I'll just pull out some of the key themes, really. So the background to the review is there are 20 areas who will be selected for a CQC targeted review, and we're in the first wave of 12. And the reason why we were selected was due to Department of Health publishing a data set on 6 outcomes or 6 indicators, of which for Plymouth 2 tripped us into being reviewed, which was delayed transfers of care and low numbers of weekend discharges as well. So that's the link back to the first item around System Improvement Board, because that's clearly the focus of that board as well. In terms of the scope of the review focuses on over 65s, and it is the letters and all the initial communications come to the local authority, but it is a whole system review, and it's looking at that whole health and social care system, from primary care to the community, through to the acute trust, through to how Live Well supports people in the community, through to how commissioners commission services as well. So it'll be a whole system review. And it looks at a number of pressure points, and those pressure points have been defined as maintaining the well-being of a person in their usual place of residence, what happens when someone's in crisis, and then how we step down people from crisis, and then that will be in a number of settings as well. CQC have adopted a methodology based around their standard key lines of inquiry, which are within the pack, and the methodology they're actually taking is fairly systematic when you come to a review or inspection, really, and that is around information gathering. So they've done quite a lot of information gathering already, and clearly some of the documents today will no doubt be used in that context as well. We have to complete a self-assessment, which is grandly titled the Local System Overview Information Request, which is based into 5 sections, which we have to populate by the 24th of November. The review then goes into site visits, focus groups and interviews as well, and that's the usual process really. And they are trying something called a relational audit, which means we, the local authority and the CCG, identify all the key stakeholders within the city around health and wellbeing, and they will send out a questionnaire to those members that we've identified as well, and they should be arriving on people's doors as we speak. And I know that some people I spoke to in the voluntary community sector and our providers have already received those as well, so they're out there at the moment, and they're looking to build up that whole picture rather than just more than you get from small focus groups, it's fair to say. And then they're also looking at case tracking, so absolutely putting the patient at the centre, seeing what went right, what went wrong for patients as well. And we have to identify six patients' files, and they will read the files all the way through, and then when they're on site they'll also dip sample cases as well. So in terms of the time frame, it creeps up quickly like Christmas, these things, doesn't it really? And they're on site for 2 days next week, 14th and 15th of November, and they have a series of focus groups then, and some visits to some services as well. Before the full week review on the 4th of December, which we're just starting to plan through in lots of detail really. And then the other key date to mention, I suppose, is the 2nd of February, which is the local summit. So this is when they present their report to the local system, of which the Health and Wellbeing Board will be involved in that, and they will present their findings, and they will then ask the system to reflect back their feelings on that and then what we're going to do about it. The expectations very much is the Health and Wellbeing Board will then own that action plan, and clearly there'll be an action plan coming out of it. So the board will need to think about how they receive the report, and then what our response is, and then how you are going to effectively monitor and drive through those improvements as well going forwards. So in terms of current activities, we are absolutely in the world of logistics at the moment, booking rooms, taxis and all those things as you would expect. We're doing the self-assessment, and I think out of that self-assessment we're trying to be as self-aware as you can really, and I think some of the issues we've identified is clearly demand and demographic pressures. I think Ruth's report was a useful contribution to that really, I think really helpful. System flow is clearly an issue which we've identified, primary care, Findings from peer reviews as well. In the past, we've had quite a lot of interventions in our local systems, and they've identified a number of themes for us, and we've responded to those and taken those forwards, principally around how the community interfaces with the acute and how we work through those system interfaces and make them more seamless for people. And then I think a really big emerging theme is workforce challenges, where across we go, you know, there are gaps within our workforce as well, and how we approach that as a system will be tested. And then the other stage we're at the moment is we're learning from others as well, and you'll see within there we've had 2 reports published so far, that first 12, and there's some headlines within there as well, and we're following those up from conversations with people who's already been through the reviews. The last conversations we had was on Monday with Manchester, who were the last area to be reviewed, and they gave us some really useful learning really. Manchester clearly devolution powerhouse, and their reflections back to us very much was, it was recognised that they've got a really strong vision, a real good journey which they're going on, but also the CQC reviewers really wanted them to explain or demonstrate what they're doing on the here and now. And I think that's a challenge for us really, to say strong city vision, we've got good plans, etc., but how are we focusing on the here and now and absolutely changing services now? And I think that's why the System Improvement Board, which Rob's convenes, a really helpful tool to allow us to demonstrate that when the reviewers land. And that's probably my overview. Carol?
Thanks, Craig. Craig's obviously given you a really good overview of everything that's going on. I just wonder, for the benefit of the board, because I think this comment that Craig's made about what we're doing in the here and now is absolutely critical, because if you think back to the start where we were looking at what the service improvements that are required, Sheila's already mentioned the primary care fragility, and we know we've got to do a number of things to help secure improvements around primary care because of the difficulties in that area. But the second area that we've really been focusing on is the work that Joe's been doing. And I think for the benefit of the board today, having Joe here, I think you need to hear from her just a number of the things that she's been leading on behalf of the system, so that we can assure ourselves today that we're focusing on the very right things, because this CQC review is really important for us. We've got to be able to demonstrate what our vision is, what our direction is, but we've also got to demonstrate what our problems are and our pressure points and what we're doing about them. And I think it would be useful if you just heard a few things from Joe, so that you could feel assured that we're on it. We may not have all the answers yet, but that Joe's trying to pull things together on behalf of the system. So I know I'm landing you again, Joe, but...
Thanks, Carol. So my role is predominantly around bonding the interface between the acute and community provider, to making sure that patients are always put first across all of the pathways that we're developing. So some of the work we've done today is we've got a discharge team in Derriford Hospital and a discharge team in Derriford that works for Live Well, and we've integrated those teams together, and their formal start date will be the 20th of November. And what that means is that we will improve the communication and the referral processes from the acute to the community, and we're already seeing an impact in terms of the number of people that are delayed in Derriford. So we've moved from an average of around 78 people delayed at any one time at the beginning of the year to about 41 yesterday. So it's a ward full of patients. It's a real significant change, and we're trying to work together to make sure we sustain that change going forward. And what the teams have done together on the shop floor is develop those processes in terms of what they understand are the best things and the right things to do for patients. We've appointed a trusted assessor, and her role is to work with the care homes to make sure that the patients discharged from the hospital into care homes go with the right level of information, and that the care homes trust the assessment and the referral of the patient and don't feel that they always have to come in. That's in its early stages, but it's proving really, really beneficial. And then some of the other work we've done is understand why people are delayed and what the constraints are in the system. So we understand whether people are delayed in their assessment pathway in the hospital, or because there's a lack of provision in the community, so that we can absolutely focus our efforts on where those constraints lie. And finally, and the big piece of work that we're doing is on home first. So we truly believe that everyone
should go home first, have a package of care wrapped around them, and have the absolute best chance of staying at home for as long as possible. And we know there's really good evidence that if you're over 65 and you've got 2 or 3 long-term conditions, and you're admitted to hospital repeatedly, then your chances of going into long-term care and your chances of survival reduce. So the best practice in those cases is to get people home as soon as possible with a rehabilitation or reablement package, and we are absolutely focusing as a joint team on moving towards a home first optimum delivery. And that is a huge piece of work, but a work in progress at the moment. Is that helpful? Thank you.
I'd like to ask, are we managing to maintain the numbers of discharges over the weekend as well as Monday to Friday?
So the numbers of discharges are not the same as the numbers of discharges during the week. They definitely reduce, but the numbers that we are achieving are sustained at the moment. We definitely have more work to do in terms of delivering more discharges at the weekend. And we have a weekend discharge project wrapped around delivering that.
Is there anything that the board can actually do to sort of like try and help to free up some of those barriers that you've got to discharging Saturday numbers being the same as Tuesday or Wednesday or any other day?
It's a difficult area purely because of some of the challenges in terms of workforce that we've been discussing, and particularly around junior doctor workforce that we know is a challenge as well as primary care. And that does impact on some of the decisions and tasks that need to be delivered. So at this point in time, I think we just need to work through some of the additional constraints and bring back some further information at a future meeting.
Quick one again. We've been looking at this a long time, haven't we? I think from our perspective, I think it's a really complex problem, and I think we have a tendency to look for easy solutions. And I think when you kind of measure the GP situation in Plymouth and compare it, people find themselves in accidents and emergency through no fault of their own, but because there's a whole raft of things that we need to be improving on. So I don't doubt, as long as I can remember, we've been working really hard to address the system, but we haven't found any answers yet, I guess. And people are turning up at accident emergency much more regularly, and I think that is an impact of not having enough GPs, and I think it's also an impact of people not being confident that they're getting the care they need in other places. So I think if we're going to reflect on this to CQC, I think we need to kind of understand how complex it is, and you know, we thought Robin Ward that would solve everything, and we didn't really take on board the complexity and the need to look a lot deeper than perhaps we have done in the past. So I just make those comments really because I know how hard Craig works, and everybody at Dartford, I'm sure, trying to solve this problem. And instead of, I'm sure we've improved it, and I'm sure it's because the numbers are going up. And I think we need to reflect that to whoever's looking at it, that we particularly understand the problems, and also that, I mean, I have huge confidence in the leadership of this board and the people, particularly the commissioning people. What an absolutely brilliant job they all do, but we're still stuck with this problem. So I think I would like everyone to reflect that, how much effort and actually how good our leadership is on this issue. Because I know I've never had a meeting with Craig where he hasn't raised it. And I think that's right and proper that there is a total focus on it. And I just make those comments because I think it's important that sometimes we do lose sight of things because we're so kind of et up with the present problem rather than looking at the big picture. And I just wanted to make those comments really.
Yeah, I mean, I agree with Ian really. we know it's such a huge and complex challenge, and it's not just about the health challenge, it's about the resource challenge. So you're trying to deal with something while you've got less resources. And it's something we've talked about here before. And what I thought was really helpful in Ruth's report was when you got to the why, what and outcomes, having more of that coming here around the whole system and different parts of it, so that we don't get completely wrapped up in the problem and the failures and the difficulties, because you have to create a momentum of change and improvement to be able to get everybody committed and feel like we are making significant improvements. And in the time I've been here, I hear lots of examples around where we're doing really good things, and unless we get that here along with the challenge, there's a danger that we don't keep as upbeat as we need to be. So it is difficult, but when we hear Craig and others talk, we know about the work that they're doing to make improvements. It's just not always articulated as clearly. So something like that, why, what outcomes around those type of issues you've talked about there, would be really helpful for us to understand as a board about what's changing within the system, as well as this demonstrates what's changing as outcomes, because it is complex when you just dip in and out. Otherwise, we're just looking at the big picture, and actually we need to understand some of the things that are going on to make those improvements, because in health, it doesn't change now, it changes over 3, 5, 7, 10 years. So you have to know about what's really happening to feel confident.
So I just wanted to give a bit of a general practice view. Mondays are the busiest of 5 very busy days in general practice now. So to be honest with you, if I put my GP hat on, the concept of weekend discharges makes my blood run cold in terms of what's waiting for me on Monday morning. Now, I'm sufficiently old enough to remember a time when if a patient was discharged from hospital, you knew you weren't going to see them for a few weeks because they would be completely sorted. Not all the time, obviously, but most of the time. Things are different now. That's not because of the way hospitals are dealing with patients. It's because of the complexity and the frailty issues, and we just can't leave those patients for long the way we used to now because they're older and more frail. So I think what I want to say is to emphasise the need to acknowledge that there needs to be a shift in everybody's approach, to acknowledge the importance of involving our out-of-hours colleagues and the local medical committee, and just to thank Joe for bearing all of that in mind, because it is a really key part in making sure that if we have a supported, confident primary care, and I say primary care advisedly, not just GPs, then I think that is a really important part of the puzzle, and I know Joe is working really hard to address that, so thank you.
After listening to that, this is probably a naive question. I was going to ask Joe, you say it's a workforce issue, particularly around junior doctors. I was wondering if there's also part of the issue on the support people have when discharged, and whether it is something that we as a community sector should be looking at as a distinct piece of work. Could we improve the support around discharge?
I think as we develop the integrated care model with the community in terms of the new work that we're doing as part of the STP, it'll absolutely be essential to ensure that that community network and the work that you talked about earlier on around making sure people are engaged and embedded within their communities and there's the right support infrastructure will support some of those isolated individuals and some of those people that access health services when they're anxious. So I think that might help with some of the preventative agenda and the work that we need to do up front. I think longer term we need to think about it isn't just junior doctors, it's a complex, as you've said, number of elements that we need to put together to facilitate people going home when they need to go home on the right day of the week, whether that be a Monday or a Sunday. And there are a number of things that we just need to collectively join up to be able to understand fully what we can deliver. So that might seem like a bit of a broad answer, but I'm right in the middle of trying to understand all of the factors at the moment. And I think if I could give you some assurance regarding the System Improvement Board, is that we have a matrix of data that we explore at every meeting that looks at everything from primary care through community services, acute social care, all the way around the whole system, that is enabling us to really understand the here and now while looking at what the impact of some of the work that we might be able to do will have one outcome. So I think you should receive that when Rob does one of his presentations at a future board. I think you'll be able to really see it. Does that make sense?
Microphone. Just going back to the inspection thing. Just looking at the people who are down for the visits on the 14th and 15th, and the need for the VCS or third sector to be involved. There isn't in the stakeholder group, and I assume the visits are chosen because they're current providers, things that are happening at the moment. I just wondered if you wanted to feed in the stuff I've been talking about that's actually happening beyond what's seen as an official provider. And I don't particularly want to volunteer, but as Pop Plus, we've got an overview of what's happening, or we could point you to things that are happening in communities, if you like.
So that's probably a welcome offer, Jackie. Certainly there have been 2 days are very prescriptive, but in terms of week 6, which is the full week, we've got some opportunity to shape that as well. So we'll have a look at those focus groups and see where we can play those in.
Thank you. I think now we go on to our last item on the agenda, and we are slightly over time, but not too bad, which is the work programme. I think these are all sort of like items on here we've agreed in the past. We have asked today for some more reports to be coming in, and Jamie, I think you'll probably feed those into the work programme for us. Is there anything anybody else wants included on the work programme today? Or if you think of something, then please contact Jamie, and we will get them included on future, for our next meeting. John.
So just in reference to what I said in terms of what Ruth has been producing, we said 2 or 3 boards ago that we wanted to start to bring examples of what was happening, what was changing, what was a good news story. Maybe we need that as a formal agenda item so it doesn't get missed out. And we might want to think about it in different areas of the work that we cover, but so that we sit here and we're talking about things and understanding some of the good practice on the ground.
I'm sorry, but just quickly to say, and I have said it to Ross and I will say it to Jamie, there was a select committee report that recommended that green and open spaces should be on health and wellbeing agendas as a really vital part of wellbeing in the city. And I'm also thinking, if we, in the voluntary and community sector, do a compassionate city move, it would be great if it could be a cross-sector one and the board could be involved in that. So I will pass those on, but I thought I'd just warn you in advance in case you want to say something.
Really interesting meeting.